right, welcome to our continued series on how we can apply tools and technologies, especially from the information age, to help reduce a lot of the burdens that we see that providers have been given, especially in the COVID era, but certainly before that as well. So provider burnout, you've heard some terms being refactored a little bit from burnout to well-being, and we heard earlier today from Wendy, especially around this idea of moral injury. So there's a lot of different ways of looking at the burnout problem. But while we have a pretty good idea and everybody generally agrees that there is a major problem, what we're lacking is very specific advice about what to do. What processes do you implement? What procedures can you execute? What tools can you install? So this next half hour or so is going to be a great discussion with Peter Durlach from Nuance. And Nuance, for many of you that have been in the industry for a while, know them well. So they have been helping with reduction of physician burden through tools and technologies and what we call conversational artificial intelligence or conversational AI today. But this has been around for multiple decades, using dictation, voice recognition to take voice recognition and turn it into clinical documentation. So they've been doing this for many, many years, and Peter's got a great background both in radiology through the older PowerScribe product that got brought into Nuance, and then of course as leading their healthcare division for the last almost 15 years. This is a gentleman with a lot of expertise and experience on the ground for how people can actually implement tools and technologies to reduce physician burden and clinician burden in general, which of course goes a long way to assist with burnout and all the other problems that we've heard discussed by our physicians and other colleagues earlier today. So with that, let me let you say a few words about yourself, Peter, and then I'll jump in with the first question.
Yeah, great. Thanks, Shahid. Hello, everybody. Yeah, it's great to be here. It's a topic that is important to me personally, since I've been in this space for a very long time, and many of my closest friends are physicians, and the business that we're in. So I think it's a really important problem, and it goes way beyond, just from a business point of view, commercially, what's in it for us, at Nuance. It's really, the amount of respect you have for clinicians and what they do for us, and the requirements that we all depend on them is you often take them for granted in my experience. A lot of people, and COVID just obviously escalated this amazingly. I mean, the stories that you see about what's going on, and most of this is still buried. I mean, but we're on the front, well, we're not on the front lines, but we're right behind the front line. The stories I hear from my clinician friends about what they're going through and how this has taken burnout to a completely new level. It's intense. It's on many levels. And so many of us feel a personal obligation around this piece. And although we certainly can't solve all the causes of burnout and Nuance, I think we can, make our small contribution to trying to help in our clinicians. And we have a phrase here, about two phrases that are important to us. One is, how do we take care of those that are taking care of us? It's kind of an internal mantra that we have. And secondly, there's a famous picture that many of you have sure seen. This is in JAMA from 2012. Dr. Bob Wachter put in JAMA of the 13-year-old girl who drew a picture of her experience visiting her physician. The physician's off in the corner, hunched down with his back to them, facing the computer. And our other internal mantras, our job is to turn the chair around. Yeah. So that's a really important topic for us. So again, thanks for the invitation.
No, that's terrific, and that is the diagram that we often use whenever somebody wants to say something nasty about an EMR. So yeah, I'm sure a lot of us have unfortunately seen that. Well, that's great. Tell us a little bit about how do you guys at Nuance, and maybe you personally, frame this problem of burnout? And I want to look at it in two ways. One is, what is there that nobody can actually do anything about from a technical processes, procedure, other perspective, and it's just a burden of being a physician because it's a hard job. Right. It's not something that's simple to do. But then there's a myriad of things that you and I certainly believe that could be solved if we thought about the problem a little bit differently than the way we do it today. Just as an example, the clinical documentation part of it if we removed all the compliance requirements from documentation and left it to say, okay, focus on whatever is clinically relevant, that could be potentially a solution. But what I wanted to do is kind of separate those two first, get your view of the 50,000 foot level, and then let's concentrate then on the second part, which is what can we do about it?
Right. No, it's a great way to frame it. So, clearly I'm sure there are many clinicians that will be listening to this. They know better than I do. But I mean, we put in a few buckets. And again, there's a ton of research. AMA's doing, Dr. Sinski's doing a ton of work. There's many other groups that have done a top. There is, obviously the regulatory requirements, right? What is being required of healthcare systems to document or to justify why they're delivering care, how to get paid. And so there's a whole regulatory environment. There's a lot of effort focused on that from the AMA and others. Secondly, a big one is loss of control, right? Loss of control is clinicians deciding what's best for the patient, how to run, the collapse of the primary care practice and consolidation. So there's a loss of the kind of special role and the professional role that a lot of these folks went into medicine for. And then there's the day-to-day that is sort of connected to both of those, which is the data shows, I think 50 to 60% of the time that clinicians spend on administrative requirements, which, as you know, is in general double the time they spend seeing patients, which you think about in itself is insanity. About 60% of that is tied to clinician documentation. So within that bucket of stuff that is affecting them, and that a lot of that's driven from the regulatory requirements and care paths and all this other thing, it's a big chunk. So there's certainly things with Nuance we cannot solve that others are trying to work on. We don't affect the regulatory side, and we certainly don't affect, loss of control of decision-making by clinicians. But on the day-to-day on the ground, what they spend their time on within the constraints of the overall system that we operate in today, we can make a big difference. And we have a lot of data to show that, because the day-to-day work is heavily centered on a certain set of tasks that we can directly affect.
Yeah, that makes sense. And so when you think about that second part now, when we're on the areas that you can impact, of course, we call this conversational AI today, meaning that you're having a human being is having a conversation with the computer, or there's another way of doing this called ambient conversations, which is I'm talking to another human and the machine is listening to our conversation and recording that. So you guys support both models slightly differently, but it's similar kinds of requirements. So in this conversational AI space, it sounds like it's something new, but of course, you've been doing this since the late 80s. This is not new. Talk a little bit about that history and why can we count on this technology to actually do something useful to reduce physician burden?
Yeah, it's really funny you mentioned that way, because we've been in the business so long, and I personally have been since like soon after my school days. We never called it conversational AI, right? And when conversational AI came out, I said, no, it's like, that's what we do. We should probably call ourselves that. It was kind of funny because, speech has been a long time and it's basic conversation. In the old days, it started, interestingly, with one of our products called Dragon Medical, we have a lot of clinicians that use this for decades and the performance has gotten a lot better. But in the early days, this is late 80s, early 90s, there was no dictation at all. You just had command, like do X, like open the window, etc. And I was actually a founder of a company called Articulate Systems that built the first voice interface for a Macintosh called Voice Navigator way back. It was command and control of a graphical user interface. And then dictation came out in the early 90s, but you had to speak like this. Not the most natural thing. Some people used it, more special needs, and some very heavy tech people that were willing to suffer through that tech at the time. And then over time, if you look at where it's gotten today, before I get to the ambient side, with products like Dragon Medical, which is used by about 60% of all physicians in the US, the performance is not perfect, but it is mind-blowing. It's in the cloud, there's no training, 28 accents, you walk up, it's really unbelievably accurate. It's not perfect, but it's unbelievably accurate. And with that is sort of the state of the art today. In healthcare, it's all neural net based, it's conversational AI, and on average, we can cut the administrative burden, the documentation down on average across those 600,000 physicians by half. So what most clinicians do is with that product, what they do is, our job is to give time, well, we do a bunch of other things, but in this context, we give time back. Now, our job is to give time back and also make the documentation better, so you get paid appropriately and your acuity capture, disease burden is captured, because all the payment models are risk adjusted. But on the burnout side, our job is to give time back to our clinicians. How they want to spend that time is up to them in the organization. So when we on average give a couple hours back a day, some organizations use that to reduce all the after hours time that their docs do, which is a huge burnout. It's famous pajama time, EHR time, whatever, so they can spend time with their family and just not be so stressed. Some use it to increase the visit length, and some people see more patients, and it's all over the map on that stuff. But we have hundreds of clients, thousands of physicians that are seeing these type of gains, and they make difference. I've gotten quotes from clients, individual docs, saying, I'm actually thinking of not retiring. It actually makes medicine more fun again. I mean, again, we don't solve, I'm not here claiming that this is nirvana and this solves all the problems, because it doesn't, but it can make a real difference. And then on the ambient thing, which we're super excited about, this is a new technology category we pioneered and recently announced a partnership with Microsoft that we're doing this together. It's a product called the Dragon Ambient Experience. About 5 years ago, myself and our CTO sat down with Karl Dvorak at Epic, and we were brainstorming what would be the future state of the encounter around documentation, because beyond the next generation of Dragon, effectively. And we all came to this realization that would it be great that instead of making the clinician see the patient and then re-articulate stuff, why couldn't we take the conversation and out of that colloquial conversation, use that an AI to produce a draft note, drive coding, drive extract, all these administrative things that take away from the clinician spending time with the patient or their families. And so we said, that's a really hard problem, technically, but why don't, if anybody's going to do it, we should do it. So we jumped on that journey, and over the last 4 years, we put a ton of money and time, and we just launched it. And it's early because we're doing this by specialty, because you have to basically build these models that recognize these by specialty. The early results are mind-blowing. We started in orthopedics and some of the more structured specialties, and we're seeing results where documentation time over what they do with Dragon. So Dragon's already an hour or two a day savings over alternatives. This is reducing that time by 50 to 75%. The satisfaction rates are average 88% higher. We're starting to measure patient sat, which early indications go up, although we don't have the hard data to back that up. And we're seeing better quality notes that we're measuring on RVU and revenue capture too, which is important because no money, no mission, all that stuff, understaffed people. And we do this all with patient consent, so the patient knows what's going on. So you actually can have a free-form conversation, and magically, this note is produced. We do in the early stages by specialty, we have a human reviewer in the process that's a remote person, make sure that there are no mistakes. If they are, they correct them, so that when the doctor gets the report, they can just quick scan and they're done. And we use that to teach the machine. So over time, it gets better and better, and eventually the human, the non-physician human, just completely gets removed from the space. The last thing I'll say, and then I'll turn it back to you, nursing. Nurses are also completely burned out. We've been trying to help solve part of the nursing burnout for a long time. Unfortunately, until the last few years, health systems in general were not willing to spend dollars on reducing nursing burnout, at least with technology. The last 2 years, that's completely shifted. Every C-suite I talk to, nursing burnout is right at the top of the list, along with clinicians. And COVID, of course, has just sent that through the roof. So much like with clinicians, we're now seeing solutions geared for flow sheets, assessments by nurses, massive, even more reduction in time, because the nursing documentation is even worse than if you've ever seen these assessments that can take 15 or 20 minutes to complete. They're nuts. They're clicking and point. It's mind-boggling. And so we've taken like 15 or 20-minute assessments down to 3 to 4. So we're really excited about now being able to bring some of this relief to the 3 to 4 million nurses in the country too. So sorry about the long-winded answer, but that's kind of what I said.
No, it was a perfect answer. So as we look at burnout, we categorize them into things that no technicians or tools or technologies or process procedures could do something about. And then there's a whole bundle of things that we could do something about. In this bundle that we could do something about, I think we've classified this into a few areas. One that's really nice is what's working right now. It's already installed and you can use it today, which is kind of like do your note, do your encounter, and then come back and dictate and get that going. So that's good. There is a second piece, which you just talked about, which we are calling ambient, but it's very similar to what you and I are doing today right now. We are talking, and ambiently, this exact conversation is being recorded, played live in addition on YouTube and others. And by the way, if we wanted to, we could actually press a button and it would transcribe all of this for us. Now, the conversation that you and I are having does not have enormous amount of medical jargon, so we'd probably get about the 90 to 92% accuracy rate on that. But as soon as you toss in medical jargon, the existing technology would drop like a rock, and the ability for it to recognize would not be so great. But that's where you guys come in with the special models for each of the specialties, et cetera. So the good news is infrastructure is now well placed. We can do this. The real magic comes in, though, from that second ambient side, now going to conversational AI with patients. So if we say, where does a physician spend their time with patients? Much of that, of course, has been administrative before the physician or clinician talks to them. Yep. So there's a bunch of stuff that happens over there that we can help automate. Then they come in and they do lab work, general Q&A, et cetera. By the time the physician is asking them something that only a human specialist that they can ask, they're actually down to probably like 50% of the work that they need to do. Tell me a little bit about, and I'm asking you to do a little bit of future thinking here, but the future thinking that we are doing during COVID is not like future thinking we were doing 6 months ago.
Right.
Because during COVID times, if I can think it, I finish the code tonight, it could possibly be used tomorrow morning, right? So that kind of future thinking that we've seen in other industries is now going to be possible in healthcare. So tell me, in that spectrum, you've got the success with Dragon, you're working on the success on the ambient side. What about that patient part of the?
It's a great question. It's a great lead in. So let me tie the last thing I said on the ambient into the kind of the patient facing digital. So obviously one of the big things that's happened, everyone knows, is the explosion of telehealth virtual visits. So number one is, in this digital transformation, the ambient thing now, it also worked in a telehealth visit. You basically can, the same thing I mentioned in the physical setting, you can be on Zoom, Teams, Twilio, native and Epic, whatever, record it, and you get the same result in a telehealth visit. So you don't have to be distracted with that virtual consult. So that's
so it doesn't have to be real time, you're saying?
It does not have to be a physical exam at all. We have about 40% of our ambient DAX volume today is virtual. Okay, so that's one thing that gets us into the kind of this digital transformation. And then on the pure patient side, the pre and post visit kind of thing, as you mentioned earlier, Nuance, we're not known as clearly for this outside because our brand is not visible. We're the largest provider of omni-channel virtual agent technology for consumers in the world. Not a Google, not Amazon, not Microsoft. BMW, Mercedes, AT&T, FedEx, Delta, all use our Humana, other people on the healthcare use it, but you don't know you're on a voice channel by speech or a chat bot. It's Nuance, but you don't know you're talking to Nuance because we're like BASF. If you remember those old ads, we don't make the thing, we make it better. That's like us. So we have taken that technology and brought it into healthcare, okay, that virtual agent technology. So there's two places we use it. One is on the physician side, and I'll get to the patient piece. When you're controlling your EHR, queuing up orders, looking for information, these all take tons of clicks for burnout. So we now, not only can you dictate, but you have full control of a number of these systems. The first EHR to jump on that was Epic. If you're an Epic client on this and you've heard of the thing, Hey Epic, that's all powered by Nuance. We're doing the same thing with all the other EHR vendors. Now switching to the patient side, we are deploying the same underlying conversational AI technology to the patient engagement use cases that you mentioned. So any pre-visit stuff, appointment checking, support, pre-collect triage stuff, wait list information, medication adherence check, all that can be done by conversational AI, voice, text, on a chat bot. We also have ability to drive that right out to the endpoint, like on an Echo or Google Home device. So our technology not only supports our native conversational AI, but we can build sophisticated dialogues for the digital front door, as we call it in healthcare, that also run in Alexa and Google in the home, all off a single Nuance-powered platform. Post-visit, how was their experience, patient education, checkup, anything you want to do around that digital front door, pre and post. We have the same technology that powers this for the clinicians. We're now bringing in the healthcare to enable you to build applications, often connected to your EHR, for the patient-facing thing. And we have a technology stack that runs in the cloud that allows us or our clients to build these with very sophisticated kind of bots. And those bots can, again, be on any channel, voice, text, email. They also intersect with the patient access center, which is the call center, as you know, inside these sites, because a lot of these use cases, you don't want to staff up all these humans to do it. You want to make them more efficient and focus on the more complex interactions with the patient. And you can't just be on the virtual channel because many interactions do involve a human. So this technology allows you to do automated stuff, but also move back and forth between the automated virtual assistant or the bot and the human with common context. And we actually getting a ton of traction on that. And COVID is just, as you mentioned earlier, massively accelerated that because the digital transformation of the digital front door and telehealth has just, I've never seen decisions made so fast as they have in the last 6 months. And these clients have seen what they can do if they really focus, and they've just been forced to do it. So excited.
Yeah, no, that's why. So as an engineer, still someone who does write code for time periods, small time periods. I don't have as much time as I used to write code. But what I am seeing is that now that I'm finishing code, and when I talk to hospitals and health systems, they're willing to actually try this out, not like a work at a pilot and do that kind of stuff. So I think what's happened is the decision making is getting accelerated. And so talk to other innovators in the space now as you're starting to understand burnout quite differently because you've been in the industry for a while. There are a lot of innovators coming into space, and our health system professionals themselves that don't know how to explain this stuff to innovators, entrepreneurs, vendors out in this, other startup vendors out in the space. How would you describe that to them to say that here's the life of what physicians and nurses and others go through, and this is really where technicians should start focusing. And remember, you're talking to probably 80% of the audiences, people in the healthcare systems that are asking for tools. So how should they inquire and ask for tools? And then the latter 20% would be those of us that build these tools and technologies. Give us some advice on how the two sides can talk to each other, especially in this time of COVID, so we don't waste the hospital and the health system professionals' time.
Yeah, that's a very deep question, and I don't think I can claim to be the oracle of that. I really, you should ask my wife about that. But anyway, so I mean, to me, it's all about knowledge of the space. It's as people in healthcare know, it's very easy to think you know a lot about healthcare, and then you really don't know anything. And so, this is the same advice I give on any deep vertical. If you're an innovator coming in, you have to sit on the front lines and experience what it's like. And if you're not from this world, that is not easy to do. Mm-hmm. Because there's a level of clinical depth and knowledge that you need for a lot of these use cases that you just can't replicate that easy. So my experience has been the successful folks have some pretty deep healthcare experience. It's not that there's not disruptors coming in, there absolutely are. And they have some real advantage, especially some of the bigger ones on some of it. But they often fail a lot, even the big ones, if they don't really have healthcare people that are interspersed with the technical people, because it's really easy to spend a lot of money and not deliver something. Also, the difference in healthcare, and then I'll get to the health system side, is in most industries, the factory worker is not the knowledge worker. And in healthcare, that's not the case. The most highly paid, most highly educated revenue generator is the physician. So the person on the front line is this uber part of the chain. In most industries, the person producing the widget, quote unquote, the product, is not the most educated, highly paid revenue producer in the company. So when you come into healthcare, you can't just build something and say, go use it, like you would in a factory. It doesn't work that way because you've got these clinicians that control. They may not feel they have control, but they have a lot of sway, because without clinicians, the health system can't deliver care, and they're not going to make any money, and they're going to die. So it's a completely different environment. On the health system side, I mean, I don't want to speak for the folks on this phone. They have more experience than I do, but I would imagine it's going to be very frustrating talking to commercial companies many times, either because they're arrogant, they think they know what they're talking about and they don't, or they overcommit and underdeliver. That's my experience talking to clients. Like they've seen all that movie 1,000 times. So they're all very jaded generally for good reason. So, my advice is dive deep into the workflow, understand the problem, understand that workflow matters a lot. It doesn't matter how good the tech is. If it's not in the workflow at the right point to affect, they're not going to use it. If you don't get the adoption, you're not going to get any of the benefits. Be humble and try to think about why they went into medicine too. They didn't just do it to make money or just to survive. They did it as a passion. And so you have to have a little bit of that passion and understand if you really want to be part of the community. Otherwise, like the antibodies, my experience, the antibodies attack, speaking about a pandemic, they reject the organism because it's so obvious when someone comes in that's not from healthcare, and they reject the organism.
Yeah, and so talk about then what kinds of things can we see succeeding outside of healthcare? What can we learn during this time, whether it's burnout related or not? There is a lot of stuff, as you're mentioning, a lot of the big players. Everybody now cares about healthcare in ways that we've never seen before. That means a number of entrants are there. There are probably many folks, whether from the hospitality industry or retail industry, that could help out here.
Yeah.
Who might those be, and what are some good categories?
Well, despite that I said that it's really difficult to succeed in healthcare, we also know that much of healthcare is broken.
Yeah.
And it's ripe for disruption. And to me, the ripest part is the digital front door, this is no shock. I mean, this is well known. The experience as a consumer of healthcare is in general horrendous. Mm-hmm. I mean, everyone has experienced. It's expensive. You don't understand what's going on. You have no idea if the physician you're seeing actually is better than the next guy. No one follows up with you to make sure the right thing is happening. And then you meet people that are all conflicting advice. It's nuts. Right. So if you're a consumer and you're from the other industry, there's so many arbitrage opportunities here to disrupt that experience. It's not easy. Some parts are easy. Like, can I schedule an appointment online like I can do an Uber? That should be not that hard. Getting good clinical advice and understanding who's better or not, that's a little bit more complicated, because what is quality? How do you do risk adjustment to make sure you're comparing it? Like, that's so I do expect significant disruption around patient access. And if the restrictions on telehealth around payment and accreditation by state goes away, I think the competition is going to massively increase, at least for the low acuity stuff, because basically then you can deliver care from anywhere with a better experience at the same rate that physical, with doctors everywhere. I think that's going to be completely transformative. I can't imagine. I'm still shocked that Amazon has not launched a virtual visit capability through my Echo Show for non-emergent, non-acute stuff. If I can just call up and find a doctor quick and do a picture and like it'd be done in an hour, like I can get a 2-hour delivery of my, milk. Why would I go even to urgent? I mean, so I think that is definitely coming. I think there are other areas that are going to be harder to disrupt, but that whole front door area, and that's why you're seeing, even with COVID, these health systems know they have to make it easier to attract and keep patients, because those are going to get ripped away if they don't. And then once you get the patient in, the other piece I'm seeing is making sure you get paid appropriately for the care that is delivered. And we're in this business. Every hospital system and every physician leaves money on the table because none of them have time or understanding or patience to document appropriately how sick the patient is and what they're doing. And that affects all the risk-adjusted payment model. So you've got to get the patient in, you've got to keep them, and then you've got to get the appropriate reimbursement for the care delivered, how sick the patient is. Otherwise, you're going to be in trouble. And again, I'm preaching to the choir here. So a lot of disruption is coming, I think, over some period of time, starting with that front door area.
Yeah, no, that sounds great. And in fact, that part of the revenue is, if you are selling software or selling technology of any sort and you don't take care of the financial side, you should rightfully be thrown out of the hospitals very, very quickly, meaning at the time of demo or whatever, because it's just, especially now, given that revenues are plummeting at most healthcare systems, and it will stay that way for 18 to 24 months minimum. And then you've got bond ratings that are in trouble at the hospitals as well. So if you're coming in with a solution or technology, processes, procedures, whatever your thing is, and you're not first figuring out how to make sure that that's affordable, you're just not going to survive. With the last question, we just got about a minute and a half or so in our discussion here. When you look across, so you're seeing dozens, if not hundreds, of hospitals and health systems of various sizes. Tell us, when you look at a hospital that is run well and is successfully deploying good technologies to reduce physician burden, clinician burden, is there a big difference between those hospitals and those that you see are not doing it well? And what might that look like?
Yeah, there's definitely a difference. And I think some of it's capital availability, a lot is leadership. So I know Rush, I think, was one of your speakers. Someone from Rush, a big client of ours. They're a great example. So they're a huge client of ours on Dragon. They're a partner on Ambient. They also did a ton of work around the Arch Collaborative in their EHR adoption. We actually helped them with that. We have a business that helps optimize EHR. They've seen just dramatic, that's an example, dramatic, and they're not alone, dramatic improvements in burnout. And again, it's technology, it's workflow optimization with the EHR. There's probably some things they're doing on life balance stuff, which I'm not aware of, I'm sure, or decision making around that. The CEO is a super sharp guy who's a physician too, friend of ours. And so that's one extreme that I know well. There are other ones that may not have the capital, not that Rush is, a huge endowed institution. They're not, right, in Chicago, but they made the commitment to that and how you allocate it. They've got a very sophisticated technical team. So they've taken the most advanced technology. They understand that it's people, process, and technology. So they've integrated that into workflow. And they have a deep leadership commitment that this is an existential issue for them. And those are the things that we see consistent. If you have that, the leadership, the commitment to the issue, and then how you allocate dollars around this whole process. Because just buying the tech, like if they just bought Dragon, they would have done okay, better. But by combining that with the optimization of the HR, they took it to the next level, right? And so we see clients across that spectrum. We see some at that edge, like Rush, that are just off the charts. It's not like every doctor's happy there and they can't do more. I'm sure they can. Mm-hmm. And then you see other ones that are really struggling, right? Really, really struggling. And so, yeah, it's like everything in life. It's focus, it's dollars, it's commitment, it's leadership to the problem statement. And you can make a big difference with technology today if you have those other components.
Yeah, and you're so right about Rush because earlier today, Dr. Brian Adabay did present around the clinical wellness model where they've taken this to the completely next level and actually have an entire wellness program around the physicians, including tools, tech, people,
totally.
And the wellness rounds and those kind of things. So you're exactly right to pick up a Rush in that particular example. So that's great. We're going to go ahead and open our panel up for more. Open up this discussion with questions from the audience. So we'll let you ride right into that. But Peter, definitely appreciate your time. Clearly a man with a good amount of passion and experience. And you put those two things together, you can make a real difference in healthcare and any other industry as well. So we appreciate your time.
Thanks, you very, very much for the time. Great conversation.